So population health, let's get the data. So we know that regrettably, what percentage of adult Americans do the following? Don't smoke, wear a seatbelt, exercise, eat their fruits and vegetables, and are at an appropriate body mass index. You got to do all 5 things. Well, the incredibly sad answer to my rhetorical question is it's about 3%. So 3% of adult Americans do the things we're supposed to do. So yeah, the observation that we are out of shape, accurate. From a clinical perspective, what does this really mean? Well, 40% of all deaths still in the 21st century are related to behavioral issues. Smoking, physical inactivity, alcohol. If we made rounds in any hospital of our viewers, 40% of all the attributable deaths are to those causes. ACC says, well, we've got to approach this in a different way. So population health then says, look, we want improved patient education. We want more primary care doctors who can then help patients navigate the system. We want to change the economic incentives to promote prevention, to promote upstream medicine, to promote the kind of medicine where we shut the faucet rather than mopping the floor. So this is going to be a multi-year struggle to change the incentives. In a word, we're trying to move from this world of volume, more tests, more procedures, to the world of value, delivering a better value for the money that we're spending. I think it's important to give the American College of Cardiology a lot of credit for, as a specialty society, for making this pivot at the national level at Hart House in Washington. They're major leaders, Kim Williams and everybody else. I think I give them a lot of credit because they're a membership organization after all, and most of their members are not engaged as much as they ought to be in primary prevention. Let me give you a for instance. Population health also says that social policy is a very important determinant of health. So let's pick the Affordable Care Act. So here we are, we're more than 6 years into it, right? Pending presidential election. A part of the ACA calls for an annual wellness visit. Pretty good idea, get patients in, especially Medicare patients, but we can thwart this with silly clinical decision making. Here's what I mean. My 87-year-old mother had her annual wellness visit under Medicare, under the Affordable Care Act, paid for by all of our tax-paying viewers, and her knucklehead primary care doctor attempted to put her on simvastatin, a drug to lower cholesterol for primary prevention. So on the one hand, of course, we would support primary prevention, but not in an 87-year-old who has never had a history of a twinge of angina or any coronary disease. So that's an inappropriate use of resources. Good idea, annual wellness visit, bad medicine. I think most people would agree to begin to implement some kind of primary prevention for coronary disease in an 87-year-old who has never had a twinge of angina. So we can thwart good policy with bad clinical decision making. So once again, I think cardiologists have done a good job through their national organization. We've got to give them kudos for attempting to make this pivot. But it's not going to be easy because people do what they're trained to do. And our viewers have heard the old adage, right? When you have a hammer, everything looks like a nail. So putting down the hammer, wondering what that nail is all about, can we approach this in a different way? It's also going to have implications for medical education at both the undergraduate level and in residencies and in fellowships, a very important additional issue.